Make sure you never miss an FX Medicine episode by subscribing to us on Apple Podcasts, Google Podcasts, and Spotify. You can also follow us on LinkedIn, Facebook, and Instagram.
Hi, and welcome to FX Medicine, where we bring you the latest in evidence-based, integrative, functional, and complementary medicine. FX Medicine acknowledges the traditional custodians of country throughout Australia, where we live and work, and their connections to land, sea, and community. We pay our respect to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. Joining us again is naturopath Sandra Villella. Sandra has been in clinical practice for almost 3 decades in Melbourne. She has a particular interest in women's health and is also a consultant naturopath and clinical leader for Jean Hales, Australia's leading women's health organisation, a position she has held since 1999. Sandra also finds time to lecture at Torrens University, where she mentors final year naturopathy students. Welcome to FX Medicine, Sandra. Thanks so much for joining us again.
It's a pleasure. Thank you, Lisa.
Excellent. Okay, so I'm going to get straight into it. We learnt so much from you last time you were on, and I wanted to chat with you again, but this time about polycystic ovarian syndrome, PCOS. Now, PCOS we know is incredibly common. In fact, it is the most common endocrine disorder affecting females during their reproductive age. And it's estimated that in Australia, 8 to 13% of females have PCOS. But really interestingly, this number increases to 20% in Indigenous women, so about 1 in 5, which is huge. So 80% of women have that classical PCOS phenotype that most of the practice listening to would be familiar with. And that's a client that's overweight, insulin resistant, hairline may be receding, but then they're getting hair in places they don't really want, like their chin, their top lip. But less discussed is the lean PCOS phenotype, which is actually on the rise. And when we talk about lean PCOS, we're talking about the woman who isn't overweight or obese and may have a relatively nutritious diet, but still has PCOS. So let's explore this a little bit further. So can you start, Sandra, by telling us a little bit about what's going on hormonally, what's going on in terms of that underlying pathophysiology in PCOS women who have that lean phenotype versus the classical?
Yes. Okay, so it is important to recognise that there is similarities even between the overweight and normal weight PCOS patients. While obesity exacerbates the insulin resistance can exist in isolation. So I'm introducing this insulin resistance because this is a key part of PCOS. So what's interesting, and I want to start this right from the beginning because I think you know how much I go on about patients always and practitioners always wanting to do estrogen clearance and thinking this is an estrogen dominant condition. I don't talk about estrogen dominance. Interestingly, this is absolutely not an estrogen dominance. And in fact, what could happen is there might be an unopposed estrogen, which I'll talk about later on, but essentially in females or those assigned female at birth, estrogen is the least important hormone here, and it's about androgens, which is like our third female hormones, and insulin. So if you think about those, they're the core drivers of this syndrome. But we need to start right from the beginning where PCOS, polycystic ovarian syndrome, is actually a misnomer. They're not cysts. These are follicles. These are like follicles that it's like failed ovulation. All these attempts of proper ovulation, of good ovulation, you've got these failed follicles. And so it's really should be called follicular syndrome. And in fact, you can have this syndrome and not actually have polycystic ovaries on ultrasound. So really what kind of happens is I think when we think about the etiology of what causes PCOS, it is largely unknown, but we do know that some of the factors, genetic factors and basically genetic factors and lifestyle have an impact. There's also this idea that in utero hormonal exposure has an impact and then obesity has an impact. So what actually happens in PCOS is that normally we've got one follicle that matures and undergoes ovulation. There's a pool of these what we call primordial follicles that are there right from when we were born. We have them when we're in utero. And usually this selection of that follicle and for it to ovulate is strictly controlled, and strictly controlled so we can maintain our ovarian reserve and ensure our fertility is intact. And so what happens with PCOS, the anti-Müllerian hormone, which is in charge of come forward, please, follicle and ovulate, there's an imbalance between that and follicle-stimulating hormone, and it causes a halt of these follicular growth. And so what ends up happening is you have this characteristic pattern of lots of large numbers of primordial follicles growing and undergoing, they die.
Yeah.
They cellular arrest. So can you kind of visualise that?
I can. Paul, it sounds so
Yeah.
sad, the dying little follicles. Yeah, so we're seeing this FSH, follicle stimulating hormone, that's not really doing what we want it to do. It's not stimulating the follicles. And then we're seeing these high levels of insulin, high levels of androgens. We're not even going to worry about the estrogen because we know that that's not really a big part here. What about, and then we see the AMH, anti-Müllerian hormone, is elevated. Tell me a little bit more about that LH, the luteinizing hormone.
Yes. So there is high levels of luteinizing hormone, and previously that used to be like a characteristic sort of diagnostic criteria, high luteinizing hormone, low follicle stimulating hormone. And so the luteinizing hormones are required for the androgen synthesis, so from these ovarian theca cells. So theca cells are an important part, and it comes from the Latin word of casing or the sheath. And so they need these high levels of luteinizing hormone combined with the low levels of FSH and the decreased estradiol synthesis, because you see what happens is normally the androgens are aromatized and create and cause estradiol, cause estrogen, that production. But the high LH and the low FSH and the subsequent decreased estradiol, because of the aromatase kind of not being working, it results in anovulation. So, and there's not this dominant follicle that happens.
And so this is obviously the same thing that is happening in classic, right? This lean PCOS underlying pathophysiology. Absolutely. We're seeing the same thing as the classical.
Same thing. It's just that you've got one less thing to work with. So normally, the primary intervention with overweight PCOS patients is a 5 to 10% loss of weight.
Exactly.
It actually addresses all the metabolic factors, it addresses all the reproductive parameters, and they usually will reinstate ovulation. Here you don't want these patients to lose weight.
Exactly.
You have to address the insulin resistance, but you don't do that by weight loss. We use all the other tools that we have to make this insulin work better and address this dysglycemia, which seems to be very similar in both of these phenotypes.
Interesting. So can you tell us more about the diagnostic criteria for PCOS and what constitutes a diagnosis of that lean PCOS versus the classical? Because I know there's a few different criteria out there, and I often think that I have a lot of patients coming to see me that PCOS maybe is misdiagnosed or even, dare I say it, overdiagnosed sometimes.
Yes, and we will be sometimes the ones who will question the diagnosis or indeed make the diagnosis. So the most acceptable diagnostic criteria now is the Rotterdam criteria. You can have oligo or anovulation. So typically in PCOS, it's oligomenorrhea rather than amenorrhea completely. So these are the people that are coming in who are having a period every 35, 40, 50 days. And this might be the first thing to alert to when you're seeing someone who comes in who's lean, who's having irregular periods, and you might be thinking, oh, they're an overexerciser, or, oh, it's functional hypothalamic amenorrhea. But you've got to be thinking, could it be polycystic ovarian syndrome? So that one you don't need tests for. It's just how often you're having a period.
Yeah.
The other criteria is clinical and or biochemical hyperandrogenism. That means the patient in front of you has got acne or they are hirsute, and you need to ask because they might be really onto waxing and laser and may not show that, or biochemical hyperandrogenism. So that means in their blood test, high androgens. It is not unusual to have a very hirsute or person in front of you or with acne who has normal androgens in a blood test. And then the understanding is there's an increased sensitivity of the androgens at the level of like the pilosebaceous unit, which is causing the acne, or the hair follicle. So increased sensitivity, not necessarily. So could have clinical symptoms or in a blood test. And the third criteria is polycystic ovaries. And when we look at polycystic ovaries, this is on an ultrasound, ideally a vaginal ultrasound, but the person has to be post-menarche more than 8 years. So if you've got someone in front of you who's 20 and have come in with, I've had an ultrasound and I've got polycystic ovaries on ultrasound, but my menarche was 15, that's not going to be accurate, because like up to 80% of adolescent girls have polycystic ovaries on ultrasound. So it leads to an overdiagnosis. So it's absolutely not recommended if they're not 8 years post-menarche. And very importantly, you have to rule out other etiologies. What else could be causing the anovulation or the oligomenorrhea? Could it be a thyroid condition? Could it be high prolactin? Could it be other causes that need to be looked at? So, the blood tests need to include looking at other factors that might be contributing to that picture in front of you.
I'm so glad you mentioned that, because I think on the Rotterdam criteria, the bit about high prolactin and hypothyroidism is in it's in like font 4 or something, like very small writing. And I think I have so many patients that present with anovulation and a diagnosis of PCOS, and they have not had their thyroid checked or the prolactin. And when we do this, often there is coexisting thyroid dysfunction or high prolactin. So I think that is really important for our practice to note down to get those tested. You were talking about the androgens before, if I take a little step back, about sometimes they're not elevated on the bloods. Are you talking about free testosterone and DHEA?
So or any of them. So generally when you have a blood test, so testosterone is tested, sex hormone binding globulin, and that allows for a free androgen index. So it allows for what I call like the misbehaving testosterone to be measured. And it's really important that the person has been off the oral contraceptive pill for at least 3 months, because, of course, the estrogen in the oral contraceptive pill will suppress the testosterone production and increase the SHBG, and it'll give a false reading. So, this is also important to raise that the pill, some patients have been on the pill since 15, 16 because of acne, and then they stay on it for contraception, and they come off it in their mid-20s, 30s, and all of a sudden they think, I've got post-pill amenorrhea. But if it's any more than, 3 months after the pill, it needs to be investigated for other causes. And partly this could be PCOS, which would have been very nicely managed by the oral contraceptive pill.
Yeah. Do you ever test androstenedione?
Not generally, but I do see it tested in the specialists and some of the GPs, and I don't routinely do DHEAS, and some of the specialists do. But so normally I would, refer off and have these tests done, and it may have some impact. But because the classic diagnosis, and I know the specialists will often consider those androgens, those adrenal androgens, as part of the criteria if the typical testosterone and free androgen index and SHBG are looking normal.
Okay. Now, you talked a little bit before about the insulin resistance as being a common kind of denominator between the classical and the lean. What are some other things in terms of symptoms that the lean and classic might, I guess, differ in?
Well, in fact, the research shows that most of the time they're very comparable. So you get similar prevalence of menstrual dysfunction, hirsutism. You get similar symptoms of also endometrial hyperplasia. And this is something really to point out, if I can just go back, because you're having these anovulatory cycles. It means that you're having these cycles where ovulation hasn't taken place. Then we don't have the progesterone production, which is going to have an impact on stopping that proliferation of the endometrium. So left unchecked, you get this estrogen building up and thickening the endometrium, and there's a risk of endometrial hyperplasia. So one of the benefits of having an ultrasound, as well as to check the endometrial thickening, and this is what I call not estrogen dominance, but unopposed estrogen. So you've got this unopposed estrogen as a consequence of of an ovulation. So still the drivers are insulin and androgen. And yes, you might have an unopposed estrogen. But yeah, you've got to keep that in mind. So the general rule of thumb is if the patient is not having 4 bleeds, vaginal bleeds a year, they possibly will, and if we can't get these 4 bleeds a year, they may need to be sent off for a progestin to have a withdrawal bleed. But there seems to be very similar sort of symptoms in terms of the hirsutism, similar hematological levels, like similar LDL and cholesterol. Everything seems to be very similar. I don't know whether you've come across anything that shows that there's differences, but the main difference is their weight.
Yeah, no, I agree. I think it's always a bit of a shock to practitioners and something for us to be aware of, because I think we often maybe worry more about that obese patient in terms of issues with fatty liver and diabetes type 2, but actually the lean PCOS seems to have the same sort of risk factors even though they're not obese. So it's more about that insulin being the problem rather than even though they're not obese. So I guess building upon that, you talked about the LDLs and the lipids sometimes being higher. What other comorbidities do you see with PCOS? What else do practices need to be aware of and screening for?
Good, yeah, that's a great point. So, the 23-year-old in front of you worried about their acne is not thinking about having diabetes later on, but there is this unfortunate progression that goes to increased risk of gestational diabetes, and I see this so often.
Yeah, me
even
too.
Someone who's with the PCOS patients, it's like, oh my goodness, I'm doing, and I think I've kind of mastered it recently, and I'll talk about that.
Tell us.
Well, I think, just a spoiler alert, myo-inositol, I think is really, and I want to really talk about that later on because I'll get to it, because then I just want to mention these guidelines that have come out in 2023, which actually the medical guidelines do incorporate myo-inositol. So I'll talk about that and remind me. But yeah, absolutely, there's this progression of increased risk of gestational diabetes, increased risk of type 2 diabetes, and that means it's cardiovascular risk. So it's really all the way along. So particularly the older the patient, the more you have to screen for, and you need to look at, the lipids, and you need to look at the insulin, well, not so much insulin, blood sugar and HbA1c, but definitely you mentioned fatty liver, which has now been changed. The name has now been changed to, it's from June of this year, to metabolic dysfunction associated steatic liver disease, so MASLD, which I think the fatty liver was a little bit too much of a too much sort of emotive sort of. So non-alcoholic fatty liver disease is now metabolic dysfunction associated steatic liver disease, MASLD.
Oh gosh, mouthful.
I know. I thought you might like that. So, and they've got and then you can, of course, there's a new category, of course, with the alcohol one in it as well. If you're having any more than 140 grams a week, and 220 grams a week for females, that's something else. But yeah, absolutely. That is a whole kind of progression with that metabolic sort of dysfunction that happens as a result of the insulin resistance.
I think, fatty liver is a really interesting thing in that lean PCOS, because again, it's not something you would associate with someone who has a relatively healthy whole food diet, and it just really shows us that it's the insulin rather than, poor diet. I found it really interesting reading about that, thinking that we often think about insulin kind of being the transporter of the sugar into the cells, but it also helps with lipolysis. So in that insulin resistant state, we see that then we get that increased delivery of those free fatty acids to the liver, which then leads to the I'm going to call it fatty liver because I can't remember what the big term is.
Let's just call it that until we get there. Yes, absolutely. And look, we know, as an aside, that 15% of lean male Australian males have got fatty liver, and you wouldn't know unless you kind of. So yeah, there is. It's more about just the fat, but it's the insulin that absolutely needs to behave itself.
Now, we talked about before when we were talking about the diagnostic criteria that there can be that hypothyroidism, Hashimoto's link with PCOS. I know there's a number of meta-analysis and systematic reviews looking at that link. Do you see that a lot in your clinic?
No, it's interesting. I don't see it. So I'm really interested in your intake, in your input on that.
Yeah.
I do unfortunately see a lot of PCOS with endo, which is really a totally different kind of two totally different conditions, and we treat them quite differently. And I don't know why that's coexisting, because we have to sort of target it. But no, I don't actually see the Hashi associated with the PCOS. Is that in your younger patients or older patients?
I see it a lot with younger patients, and within the research there's a lot of links showing that women with PCOS have higher TPO, thyroid peroxidase antibodies, compared to controls. And I think a part of the hypothyroidism kind of picture is that you need T3 for ovulation to take place. So if you don't have enough T3, then obviously you're going to have the cysts on the ovaries and that anovulation. So sometimes for me it's just about increasing that T3 and then ovulation takes place, and it's
interesting.
that's all that's going on. So
it's interesting. There's some research with myo-inositol and Hashimoto's, which I could never get my head around, and that now possibly, if there's a similar, certainly using it for the PCOS patients, it's sometimes difficult to get the thyroid antibodies tested. You kind of really have to push for it, but that's an interesting one that I'll need to look out for a bit more. I think while we're thinking about screening, one of the other things that is often measured, and it's usually the specialist rather than the GP that test for this, is the 17-hydroxyprogesterone.
Okay.
And that's particularly tested if you've got someone who's really quite hirsute. It's a symptom of androgen excess, and that's really to rule out any sort of late onset adrenal hyperplasia or a tumour, because that we have to rule out those unusual or rare conditions as well.
Absolutely. Is that something you've ever come across in your clinic?
No, but all the specialists routinely test it.
Yeah.
Particularly in the young hirsute patient, just to make sure that it's to rule out that as a differential diagnosis of an adrenal tumour or an adrenal hyperplasia.
Yeah, great. Okay, so we talked about how weight loss is considered, the first line of treatment for women with that classical PCOS, and it's obviously not something we want to do in the lean. What about dietary recommendations for lean PCOS women who don't need to lose weight? What are you usually suggesting around that?
Yeah, that's a great question, because we still have to address this insulin resistance. But rather than lose weight, I will use a low GI diet, ensuring protein at every meal, but incorporating some low GI carbohydrates to ensure that they don't lose weight. We still have to get them eating in a way that's helping with addressing that dysglycemia. And so, often these patients, unlike yours, mine are sometimes eating pretty badly. So they will need a little bit of adjustment into what they're eating. And, some of these patients have got, 5, 6, sometimes 8 serves of carbohydrates a day. So I would often limit that to absolutely maximum of 3 good low GI carbohydrates.
Okay, and so are you thinking things like quinoa, like sweet potatoes, that sort of carb?
Yeah, look, it depends on the patient. Sometimes if I'm really going from like a white bread eater to, I will even just use like the Baker Institute guide of the plate, because they actually listed this really, I'm not going to reinvent the wheel, where they've got half the plate of veggies, quarter of the plate of protein, and then they'll list the low GI carbohydrates. And so that might be quinoa or brown rice, or limiting the sweet potato, or they'll talk about, legumes where that fits in. But, certainly getting away from the white squishy bread.
Yeah, okay. What about the old flax seeds, our fave? You're famous for your juicy flaxseed muffins.
Yes.
I know you recommend them a lot in perimenopause for hot flushes, vaginal atrophy and that sort of stuff. But what about their use in PCOS?
Sadly, there isn't a particular use for them, however, except if these patients are constipated, and you can use them for that. Look, I must say this can be my opportunity to get on the soapbox about seed cycling, which is one of my bugbears as well, which is a gross extrapolation of a little bit of research on flax seeds, which I do use to lengthen the cycle generally in patients who've got short cycles. I don't know where this seed cycling comes from. One person rehashes what the other person says. And it's, look, probably the reason people feel good on it is all of a sudden they're having some fibre and some good nutrients. But no, flax seeds I will use here as a good form of fibre, but not anything particularly for PCOS.
Mm-hmm. So when we're talking, I've just thought, I know what seed cycling is, but I just wondered, some people may have no idea what we're talking about. So seed cycling is when, I guess there's a recommendation to do specific seeds at different points of the cycle, right? So flax seeds, is that in the follicular phase?
I don't know.
And then
I don't want to promote it. I want to look, it'll probably do no harm, but
yeah. No, definitely no. Okay.
Well, it'll do no harm. It just annoys me. Now I'm feeling like, I'm being like a grumpy old woman. It annoys me when we it's a discredit to our profession, I think. And most of it is not necessarily us. It might be social media rehashing someone else's idea about this is going to sort your cycle out. And it's like, well, probably won't hurt.
But, Well, I mean, I think probably having a range of seeds, flax seeds, sunflower seeds, pepitas, all that sort of stuff, but not just at specific times in the cycle, but just throughout the whole cycle, right?
Yeah, I reckon. Yeah.
Okay.
And this is going to be good because they are low GI, they're high in fibre, all the things that we know classically are going to improve the way that our insulin and blood sugar regulation works better. So in that regard, yes, bring them on.
Okay. Great. Well, good. I thought the flax seeds were getting a bit of a bad rap from you for a sec.
No way. They're one of my top 5 foods for women. Yeah, they're still up there. Don't you worry about that.
Okay, good. What about vinegar? One of my faves.
Well, you know what? It's funny. I used to poo-poo the whole apple cider vinegar thing, and students would be prescribing, and I said, "No, what are you talking about?" And then anyway, just recently, I was reading a Medscape thing, and it's actually it's
a
showing.
thing.
It is. It helps with the way blood sugar regulation is. So maybe I'll hand that over to you. Tell me, Lisa. You see, I'm Italian. I just put it on my salad, and I have been known to drink the vinegar and oil at the end of the salad. But now I am being more open to the apple cider vinegar.
Well, there is a lot of research on vinegar. It's been studied a lot for type 2 diabetes. Again, we're seeing meta-analysis, systematic reviews. But if we kind of take on the mechanism of action of what it does in type 2 diabetes, and it's improving insulin sensitivity, and it's the acetic acid component that basically delays emptying of food from the intestines, thereby helping balance blood sugar and improve that insulin sensitivity. They've also done studies in type 1 diabetes, and also there's a couple of studies in gestational diabetes. So I think it's a similar sort of thing that we see in the PCOS woman, where that insulin is the issue, that giving vinegar has been shown to help. Now, I'm talking this up a little bit, but there's only been one little study in women with PCOS, very small, seven people, so, not the best in terms of rigour. But basically they were consuming, I think it was something like 30 mils of vinegar, so not a huge amount of apple cider vinegar, and it helped to regulate that FSH-LH balance. So it decreased the LH, which then resulted in less of those high androgens, and it improved ovulation, I think, in 4 out of 7 of those women within 3 months. So, you're looking at about a 50% kind of working there out of those women. But it's kind of cool because vinegar is so easy to do. And I also like the way that, you said you have it over your salad with a bit of olive oil, because I think that's a lot more enjoyable, a lot more tolerable than having it in the warm water, which a lot of people kind of struggle with. It's quite burny and sharp first thing in the morning. So, doing that with your food, I think is great for any woman that has PCOS.
What sort of doses, Lisa, do you remember what that's being used?
Yeah, I think they talked about 15 grams of apple cider vinegar. So I think that's literally only I usually suggest for my clients doing a tablespoon with your salad at lunch and at dinner.
No, one of my favourite aunties, so we would wait at the end of the meal. She would grab the salad bowl because we're Italian, so there's always a salad, and we would watch, and then she would pick up and she would eat Now, of course, drink the rest of the vinegar and the olive oil. And, of course, we'll have olive oil, and we know how good olive oil is, so maybe that's what we should be doing, just picking up the bowl and drinking the salad.
Oh,
but we have
yummy.
to do the salad before the meal, don't we, now, for the helping with and you drink the vinegar and oil. Yeah, that's easy.
Delicious.
I'm converted.
Okay, so we've got the lean PCOS woman sitting in front of us. Treatment aims centering around improving insulin sensitivity, down regulating the androgen synthesis. We're not going to worry about the estrogen. We're giving vinegar, maybe some flax seeds. And tell us about the minoxidil that you were talking about before.
Yes. Okay, so let me talk about, first of all, these new guidelines that have come out. This is the update of the 2018 one, but basically Australian researchers and clinicians are quite prominently featured in it. Mm-hmm. And the difference between the 2018 and the 2003 version is, in the first one, minoxidil was considered experimental, but they have dedicated quite a role, quite a lot of information to myo-inositol. And so it really is, inositol is a secondary messenger, and it has a role in insulin signalling transduction. Mm-hmm. And so it helps promote glucose uptake, which is what we want. And interestingly, they quote here that it's also involved in FSH-mediated pathways, which impact the proliferation and maturation of the granulosa cells. So they've really gone into it. And while some of the things they talk about are still a little bit experimental, they've got studies that are comparing it to metformin with the way that it helps cycle regularity with less side effects. They quote the use with IVF, and certainly in terms of helping with fertility. Now, it's important to think about when we look at PCOS patients as talking about subfertility, not infertility. These patients are not infertile. Often reinstating ovulation, well, in the overweight patient is much easier, like in terms of that weight loss. But, yeah, it's a subfertility.
I love that you said that, because I feel like a lot of patients feel so disempowered, like with the term infertility, and it is just subfertility for a lot of these women.
Subfertility, yes. So, look, it's an interesting one. Most of the studies are done on an Italian formulation that's combined with folic acid, and the dose seems to be around 2 grams either daily or BD, and well tolerated generally overall in terms of how it works in helping with that insulin and glycemic control. And some of the research looks at improving cycle regularity, looking at I think there's even studies looking at what skin improves, but it's certainly it's the only complementary medicine that's listed in those guidelines, in these evidence-based guidelines.
So, Sandra, can myo-inositol be used in combination with metformin? Do you ever do that in your clinic, like someone's on metformin and you use myo-inositol as well?
Yeah, that's a good question. I have done. Interestingly, I tend to go for alpha-lipoic acid rather than if someone's already on metformin, and we're trying to not let them go up to the 1,000 milligrams, because often the gastrointestinal side effects like the diarrhea kick in. So myo-inositol is still kind of the new kid on the block, but it's got the best level of evidence. But going back, there was a very small study done on lean PCOS patients where alpha-lipoic acid was used, and of course that's insulin sensitizing, and so we don't want to forget about that one. So I probably tend to use that one with metformin and myo-inositol in isolation, not with metformin, but usually combined. I'll often combine it with our other typical chromium, magnesium, cinnamon, the things that we also know that help with our insulin-resistant patients.
Fantastic. And, I mean, I saw a study where they gave teenage girls with lean PCOS, and I guess, it's hard when you were talking before about when women are quite young and their ovulation isn't established to whether they really do have PCOS. But they were looking at the women with lean PCOS taking metformin versus the pill versus both. And the women who were taking the metformin versus the OCP, they had less metabolic dysfunction, which I thought was really, really interesting. So it is something that can be given to those younger women too.
Yes, it depends if they go and see a gynecologist, they get put on the pill. If they see an endocrinologist, they get put on metformin. There really seems to be this kind of combination. And that's the same with us. What are we going to do? Do we address either or do we address both? And the patient in front of us who comes in with acne, we're going to treat differently to the person who's, in their late 30s and wanting to get pregnant.
Yeah.
So, it's this, again, individual treatment. But yes, so often sometimes the pill depending on the pill, can often worsen some of those metabolic parameters.
Yeah, okay. So we've talked about nutrients. What about herbs? Do you have any faves? I know with the classic, people tend to kind of gravitate towards the licorice romania, but is that the same for lean PCOS?
Yeah, so again, it depends what the patient is wanting. So if someone comes in and they have acne, and I will just kind of look at diet, look at the classic things that we'll be looking at diet, and we'll not necessarily use herbs. If I'm going to use herbs, I'm actually using alteratives. I don't think targeting the androgen type of mechanism with acne works so well. But the classic PCOS herbs are peony and licorice. Now, the peony and licorice, based on a Japanese study of this, China study, there was the similar formulas in the Japanese Chinese medicine. Peony and licorice help to reduce testosterone and for cycle regularity. So that's the classic combination. And our colleague Susan Arentz did a beautiful study using PCOS, one of probably the best studies that we have on herbs, really well done. Now, this was on overweight patients who were trying to achieve pregnancy, and she had a lovely control group where they were overweight and was just diet and exercise, so that was really good, and it did improve ovulation rate and pregnancy rate. So I wouldn't use peony and licorice for everything, but if I am trying to work on cycle regularity, re-establishing ovulation, and the diet and lifestyle hasn't worked, I will use that. And usually I'm a non-Vitex user for PCOS, interestingly. There's two schools of thought. I'm Ruth-Tricky trained. We definitely didn't use PCOS patients with Vitex. It tended to worsen cycle regularity. I know a lot of practitioners do use it, and I just watch and look, and I'm not ruling it out, but I tend not to use that as my first line of intervention.
Okay, interesting. I'm surprised to hear you say that when I know how much you love Vitex.
Love Vitex, yeah. I've got a sheet on to Vitex or not to Vitex, and everything's to Vitex, but Vitex, not to Vitex with PCOS.
Okay, I also don't use it. What about black cohosh?
Yes, interestingly, I think there was a study where PCOS patients, they were having some sort of fertility intervention, and black cohosh tend to increase the outcome, I think the pregnancy outcome. So interesting one. So I don't rule it out. It's not one that I use routinely.
It's one I use a fair bit for PCOS. I think, again, it wasn't really on my radar till I read that study that you're referring to, and they were talking about how black cohosh actually works for women with PCOS because it seems to decrease that high LH, which I thought was really interesting. But again, they didn't use it in isolation. They were using it with Clomid, which is an ovulation inducer.
But they also incorrectly refer to it as a phytoestrogen, so I'm not sure they have the full understanding of it. But we do know black cohosh lowers LH. That's a good point. And that's probably why it was important.
What about St. Mary's thistle? Do you use that a lot? It's one of my
Not
faves.
routinely, but the liver is important, so I would probably tend to go more towards Berberis vulgaris because of the berberine, like traditionally herbs, bitters help with glycemic control. Now we know isolated berberine really, it's sold in China as an over-the-counter formulation that, there's studies comparing it to metformin with PCOS, comparing it to the pill. So I would tend to go to Berberis vulgaris rather than St. Mary's thistle.
Yeah, interesting.
It's not quite, it's kind of more of that traditional use of bitters working, and it will have a slight liver action rather than St. Mary's thistle.
Yeah, there is a lot of research coming out with berberis, for sure, the berberine component. It's not something, I don't know why I haven't used it. It's something for me to think about. I like St. Mary's because of that fatty liver aspect. And I was thinking there's also good research coming out on it with regards to its ability to improve insulin sensitivity. So it's kind of, that's where I was thinking of it for that.
Okay, absolutely. With what we used to call fatty liver, yes, I would use it. Yes, absolutely.
What about adaptogens?
Yeah, good point. Like, of course, we're looking at one sort of very important endocrine pathway, and we've got to look at the very second one that's important, which is, that whole hypothalamic pituitary adrenal axis. Yes, so adaptogens, like anything, we are naturopaths, we're going to look at the individual. If there's stress going on, if they're on this stress treadmill, adaptogens are going to be important to use.
Yeah. How long do you feel like you need to use all these therapeutics for to get an improvement with the cycle? Because, some women really struggle with this irregular cycle ongoing for quite a long time. If you were going to forecast, what sort of timing would you usually see in your clinic for an improvement in regularity?
My general rule of thumb is look at it over 3 cycles, but that's someone who has a cycle every month. So someone who has a cycle that might be every 35 to 45 days, you might need to give it a little bit longer. And also you need to kind of consider these patients might be going on these medications for a longer period of time. So if it's someone trying to achieve pregnancy, they might get pregnant and then you just have to then continue to look after the cardiometabolic risk factors long term. But I think it's going to be an individual sort of case by case, but certainly no less than 3 months. You've really got to give it that amount of time, 3 to 6 months, to see the impact on cycle regularity, anything to do with the hair.
Yeah.
So if you think about hirsutism, any of the pharmaceuticals that work on that do not start working before 6 months and more likely 12 months. So that's the most frustrating. So I'm saying to a patient, you're really going to have to take this for 12 months before we rule out that it's not having the full impact and whether it is having an impact. So I think that's a good kind of one to consider.
Definitely it's good to get that idea in terms of the timeline, because I think, probably like everyone, we kind of want results straight away, but hormones, unfortunately, doesn't always work like that, does it?
No. Look, the hirsutism is a challenging one for patients because it really does impact self-esteem and their body image. And so mostly these patients are also going to be having some sort of laser or electrolysis. And if we're going to do it, so I tend to, look at the zinc. I tend to, there's some research done on spearmint tea, interestingly.
Yes.
But conversely, if they've got the female pattern hair loss, which is characteristically that widening of the part, I tend to use some saw palmetto, some serenoa. But again, you really need to look at that over a longer period of time, 6 to 12 months. And, I think that's a herb that's untapped. There probably is an ovarian action with serenoa that we haven't really tapped into. But, it's the hair, the excess and then the loss is longer term minimum.
Okay. That is a really good tip, because saw palmetto is typically, we think of it as being that prostate herb, right? But for female receding hairline, we're going to be thinking about the saw palmetto. Excellent.
Yeah, saw palmetto. It's a bit of an extrapolation on some research that was done on male pattern hair loss, which is a similar driving. And I think it was done topically. And I've used it, and clinically it seems to it's probably one of the best ones we have for the hirsutism, for the female pattern hair loss. As well as, we do have to make sure that these patients are having biotin, like 2 milligrams of biotin is also important for the female pattern hair loss, and making sure that they're not low in zinc, or that they're hypothyroid, or that they're low in iron, and all the other factors, or they haven't had stress 3 months ago, that is increasing their hair shedding.
Oh my gosh, so many juicy tips.
Yes.
Thank you so much for joining us today, Sandra. You've really highlighted that while women with lean PCOS may have a different phenotype compared to that classical PCOS type that we know so well, they still demonstrate similar risk factors when it comes to things like type 2 diabetes, fertility, fatty liver and so on. I think that's so important for us to remember as practitioners. You've given us some great tips on minoxidil for us to use that with our lean PCOS women, and I couldn't finish without highlighting that last gem you gave us on saw palmetto for reducing hair loss. Thank you so much for joining us again today, Sandra.
It's my absolute pleasure, Lisa. I love speaking to you. I love getting your insights into this, and my mouth is salivating at the thought of going to have some apple cider vinegar now.
Thank you everyone for listening today. Don't forget that you can find all the show notes, transcripts and other resources from today's episode on the FX Medicine website. I'm Lisa Costa-Bir, and thanks for joining us. We'll see you next time.
This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.
If you enjoyed this episode, please take a moment to give us a rating and review on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to FX Medicine, and share us with your family, friends, and colleagues.